They wanted me to speak this afternoon in hopes that you'll be happy enough to come back tomorrow and hear more of it. I'm doing a lot of stuff tomorrow. This is called a Richie Rant. I don't like disclaimers for talks, but I'm going to tell you that I didn't pick any of the topics this year. They picked them. And it's been a challenge, but it's given me the liberty of doing whatever I wanted. A Richie Rant is a simple thing. I looked up what a rant is. It's a bombastic, extravagant speech or with bombastic language. It can be noisy, excited, or to be scolding, and it's bombastic. So I'm not going to do that. I'm not going to rant, but I am going to preach a little bit about things that make me crazy. And there's three things that I'll do in 10 minutes. Number one, I'm going to talk about viral testing in young infants and how it can lead you into trouble. Talking about Lyme disease in a limper. And number three, I'm going to talk about people who barf. That sounds like a fun job. Let's start at the top. The first thing that's annoying is that in young kids, assuming that it's only a virus at work here. A few years ago, I gave a lecture about respiratory illnesses, and I said the road to hell, here it is again, is paved with Zithromax. Well, it is currently paved with viral testing, and I'll show you what I'm getting at here. There was a discussion back in the day where it said that if you had a positive aspirate for RSV and you were febrile under 2 months, you didn't have to do anything to work up bacteremia or serious infections. You were fine, and that no testing was necessary. So that was the mantra that went out. Well, everything I'm going to talk about in the next 2 days is literature-based, and there's an article back in 2016 about just that question. Does RSV protect you? Look at the age here, 28 days and younger, febrile neonates. Now, you know what we do with those kids. We admit them, we tap them, we park them. End of story. They got a septic workup in this study, and they also got tested for viruses, and they wanted to see who had the bacterial disease on top of the virus and those without it. And you'll see where this goes. The prevalence of the positivity was 6% in RSV, of which 98%, 378 patients had the holes punched and the nose swabbed. The positive RSV group, I think I've got a code here, the positive serious bacterial infection rate, if you look between the two viral testings, were remarkably the same. Having RSV was not protective, and you have to do the workup in febrile babies under a month. So let's put that to rest. Don't tell somebody you just have metapneumo or paraflu. You've got to punch the holes. Okay, that's one study. Second study in 18 looked at older kids under 2 months. Again, that gray zone of are you immune competent and can I examine you? The same idea. Let's look at them, do viral testing, and see if we can rule things and rule it out. There were 60 days and younger, there were 2,945 viral tested kids. Look at the data. 3.6% had serious infections if they were viral positive. That seems like a low number, but these are young babies. And the viral negative, it was way up. And the conclusions here, look at bacteremia and UTIs. Negativity is not positivity is not protective. You're stuck. Just don't write it off. Consider doing the labs. We'll talk more about fever tomorrow in other flitch. Let's talk about Lyme disease for a minute. You all know this. The Kocher or the Cocker criteria. I think, how many of you have seen these for septic hips to look at ruling them in or out? This is worth a look. The ortho guys love this. The ortho, they love a lot of things that I can't fathom. This is a score that's listed for the predictability of a septic joint. Sounds good, but wake up. It doesn't include Lyme disease. So this is an article I wanted you to highlight, and I've done this before with you. There's a prospective study in kids under 21 who were evaluated for Lyme. The docs were asked to estimate what they felt was Lyme disease on a 10-point scale, and the definition of whether it was really Lyme was whether the migrans lesion was there or a two-tiered serology results for Lyme disease. All right? The results are simple. There were 1,000 kids, median age of 9. 23% had Lyme disease. The suspicion of the disease, a quarter of them matched up. Clinical suspicion, unfortunately, in their study didn't really predict whether you're going to be positive. Take a look at the results here. I want to show you the table for the sake of time. Here. If you look at clinical suspicion recorded, look on the bottom here. The unlikely group, which was half of them, 11% had Lyme disease, 1 out of 10. And in the very likely group, 30%, they were predictive. And the take-home here is shut up and get the Lyme testing on every limping patient or any other symptomatology that matches Lyme. This has taught me a lot in the sense that we have to get on with what we're doing. How many of you see a lot of Lyme disease? How many of you? Come on, it's not an AA meeting. Tell me. All right. It's part of the day-to-day. So do the workup, make sure your hospital has the testing available, and in kids, it's mandatory. It's amazing how much of this meeting is centered around bowel complaints. We've had diarrhea. I'm talking about constipation tomorrow. I'm starting to sense a theme. My third pet rant is not aggressively treating the infant or child with vomiting. And I want to show you the power of emergency medicine and the empowerment of what we can do for treatment regimens that people generally don't care about outside of where we work. Once upon a time, antiemetics were contraindicated in kids for viral gastroenteritis. Compazine, Phenergan, and atropine had more side effect than antiemetic properties. I think everybody here could agree with that. Then along came ondansetron, all right? First of all, ondansetron is too awkward to say, so forgive me, I'm going to call it Zofran, right? Number one. Number two, it's off patent now, so it's cheaper. First article I want to talk about is, should it be black box? Does it have a problem with dysrhythmias? Well, Peds Emergency Care did a study in 2016 of IV Zofran on the QT interval. They basically had cardiograms done at baseline after they got the drug and at 1 hour post-peak effect. Great study. Peak effect of IV ondansetron is listed at 3 minutes. Take a look at the results. 100 patients, mean age of about 8. The mean baseline QTC was 435. And basically, the mean change in QTC was 3 milliseconds. The change at 1 hour post-peak effect, again, was 3 milliseconds. And there was no change later. And the take-home for this quick study is it doesn't affect the QTC. Strike one against the other critics. How well do we distribute Zofran? This is a study back in 12 of how resulted it is out there, how many people use it in their practice. Let me ask you, how many of you have Zofran in your home? How many of you took Zofran before my talk? Well, look at this. 12,000 patients, 38% of the 32,000 they studied had nothing wrong with their stomach. The non-GE patients, for the sake of time, here's the study. They had fever, they had belly pain, they had head injuries, they had pharyngitis, they had viral infections, they had otitis media. The discharge diagnosis, the admission diagnoses are listed. Appendicitis, asthma, pneumonia, and diabetes. And the take-home here is use Zofran. I'm ending with this. This is empowerment. The use of a triage-based protocol called ZoPoGo, which was invented in Syracuse. If you see it on a t-shirt, send me $1. All right. Number one, methods in this. They looked at a protocol prompting triage nurses to see who could use a hit of Zofran or oral rehydration therapy. These were patients from 6 months to 5 years. If you look at the results, 128 patients, toddler age, Zofran use went up to 75%, times to getting it went down to 30 minutes, called in the waiting room. Documented oral rehydration increased to 100%. Number two, blood testing dropped. IVs dropped. There were no significant changes in how long they stayed, whether they were admitted or unscheduled return to care. And a triage nurse, in conclusion, can take care of this nicely, and often you just discharge the child from your room. So keep it in mind as a real research protocol that you can use, and ZoPoGo is firmly endorsed by most EDs for children in the country. That's my rant for this afternoon. I hope I see you tomorrow. I will tell you that I want to highlight one of the things I saw earlier today. The girl with CF pointed out so many cogent things that I think we all in emergency medicine could take things from. But the most important thing she taught me is that the more you talk to your patients, the more rewarding it can be. So just a minor moment on that. With that, somebody clapped. With that, I'm closing on time. But don't forget to use the ultimate antiemetic, Cheetos. Cheetos cure all nausea. That's the girl with the positive Cheetos sign, which was invented in Syracuse. I want you to go out tonight and I want you to make some really bad decisions. You're in Vegas.